This is Michael Saltzman from Blue Sky Bio. I'd like to start off by sending our sincerest and best wishes for health to everyone and a speedy recovery to anyone who may need one. At Blue Sky Bio, we periodically run dental education webinar series to educate dentists both on our software, our products, and also on a wide variety of clinical topics. Usually, when we run these webinars, we broadcast the webinar a week or so, stretching over several months. The current situation and the fact that dentists may have more available time has led us to change our approach and organize webinars almost daily. We have chosen 1 p.m. Eastern Time, as it is a good time for those on the East Coast of the United States to take lunch breaks, and may also work well for dentists joining on the West Coast in their morning and afternoon and evening for Europe or other Eastern countries. Webinars will all be recorded and made available via our website and social channels for those who cannot attend the live broadcast. The webinar schedule is still being developed, but we already have 10 or so webinars scheduled, listed on our website, blueskyplan.com/webinars 2020. In addition, we have started a Facebook group, just turn this off, Viral Dental Education, to create a platform and encourage other educators to create educational opportunities during these times, either in conjunction with Blue Sky Bio or independently, and we encourage educators to post to the group or contact us. We have a great list of all-star educators, and we encourage other educators to join and dentists to reach out for cooperation and education. We can all help educate each other, and with God's help, this time period will pass. We'll return to our schedules, improved, more educated, and stronger than before. Some technical points regarding the webinars: we'll be sending out the CE credits within a week or so via email after the webinar presentation. And if you have questions during the presentation, please enter them into the QA chat box, and we'll try to address them during the presentation. The first presentation in this webinar series will be given by Dr. Robert Mikhli. He will be presenting today's webinar presentation on the topic of biological basis of implantology. This is a first of a 3-part series that he will be giving during these webinars over the next week or two. Dr. Mikhli practices in Brooklyn, New York, and lectures extensively on digital dentistry and implant placement. He also runs an in-office mentorship program providing hands-on instructions for implant surgery. Robert?
Hello, everybody. I'm going to grab your screen, Michael. Okay, and welcome everybody to the first part in this series. Just turn this to full screen. There we go. Okay, so welcome everybody to this series. It's an honor to be the one kicking this off. And a shout out to Corey Glenn. This was his brainchild, and to Blue Sky Bio for grabbing it and running with it and putting up some all-star presenters to help us all through this period. You know, when we're in practice, we're all too busy to do a lot of things that we want to do. We're practicing and we're seeing patients, which is great, but we always are finding that time to refresh and sharpen the saw is always a challenge. So as difficult as this period is to be going through, it's always an opportunity. You know, as this coronavirus first kind of got us all by surprise. Amazing how the world can flip on its head in a matter of days and weeks. But, you know, the first thing is obviously don't panic. You know, we're in an industry that tooth problems don't go away, for better or for worse. So the cases will be coming back. We will be busy again, and we'll be looking back to a time and say, you know, I'd love to have a couple of days back, you know, that I have a whole day sitting at my house instead of being worried about, you know, my practice and getting through this time, but use the time now to grow and to do those next skills, add those next skills to your practice that you've always wanted to. The economy obviously will be slow for a while as we rebound. We hope that to be a very short curve, but we know it's going to be there for a little bit. So we're going to have to do more with less. We're going to have to offer our patients solutions to make things fit in budgets that will be a lot smaller than we all intended them to be a while ago, unless, of course, you work for Zoom or a few industries that are doing well. Most people will be somewhat depressed. Disposable income will be down for, again, hopefully a short period. But that doesn't mean that our industry is going away. We have a lot to offer people. Again, those problems that people are holding off of doing will come back, and we'll be needing to get treatment, but we're going to have to be just a lot smarter with what we're doing in order to offer that treatment to patients. You know, as the CDC says, keep calm and wash your hands. That's all true. We want to keep calm and move forward in our careers and just add the skills that we can offer more to our patients in-house than we could prior to this. You know, as they say, in the midst of every crisis lies a great opportunity. It's just a matter of perspective, how you're going to look at it. The more we look at it as an opportunity, the more we feel empowered and we can move forward and really build. The more we look at as it pessimistically and say something that this is a time where we're just worried and full of anxiety, which we all are, we put those aside and we just move forward with the time that we have. And you know, Lab Pronto is a great tool to be able to do that with. We'll be getting into later on down the road, you know, building surgical guides and things like that. There'll be some great lectures on that. And a lot of it is, how do I get the learning curve up? So we're going to be spending time now discussing how to gain those skills, but the skills will still take some time. So you'll learn a lot of the skills during these courses, and you'll be able to implement them. But in order to lessen that learning curve, you can get started right away. As long as you have the basic skills of looking at CT scans, a lot of the other stuff that we'll be teaching can be outsourced. So if you look at Blue Sky Plan, Lab Pronto, which is found on the Blue Sky Bio and Blue Sky Plan websites, you can click on any of the services, or then take a look at just ordering a surgical guide. That's as simple as a couple of clicks. You can have the treatment plan only. You can have a surgical guide fabrication, where they'll send you the STL file and you can print it yourself, or they can fully do the surgical guide for you, have it printed and delivered to your office. So as much as you want to get involved in it, you're welcome to. As you see, I've got a couple of printers behind me, a curing box, we've got the desktop scanners. I like to tinker with a lot of this stuff, but it takes a long time to really get into it, and it can sometimes be a large expense. So Lab Pronto helps you just cut the line. You can already get going with this stuff with basic knowledge and get it working in your practice. So again, it's quick turnaround times. The service is fantastic. Prices are great. And it's really a phenomenal tool. I use myself sometimes when I'm just too rushed to get things done, and then something printed quickly. I can upload it, get it sent to a lab, either printed or milled, and whatever needs to be done is sent to me within a couple of days. And I found the work to be outstanding. So it's really a great tool. So without further ado, just to get into the course, we're going to be doing 1 hour tonight, which is going to take us to just till, again, 2 p.m. Eastern. We're going to get into as much as we can here. We got a 3-part series, so we'll kind of break it up as we go. You can reach me at this below email address for any questions tonight. We'll have a question answer session. I think we'll start it at 2 p.m. The questions, if there's any pressing questions within, just type them in. Michael will read them out to me if there's need something clarified. But any greater in-depth, you know, fortunately, unfortunately, I got nothing to do the rest of the day, so we can sit here and talk for as long as you'd like about details. But if you have any more pressing questions, you can reach me at this implantmss@gmail.com. Just jot that down. Send me whatever you'd like, and happy to discuss in great detail. Okay, just a little bit about me. I went to Stony Brook in New York. I did my general practice residency at the New York Hospital of Queens. And I did my fellowship in oral maxillofacial surgery, implantology there as well. Then went into full-time practice as a surgical specialty practice in Brooklyn, New York. I run a mobile surgical solution company where we send doctors out to offices throughout the tri-state area around New York to place implants in your office for you. as well as the implant mentorship program, where we teach hands-on, getting you started in implants and progressing within the realm of implantology. We're actually looking at, in the not so distant future, about launching a virtual version of that, where we will, through a similar format, be in your office virtually. If you're wherever you are in the world and you want to get your own surgeries going, we'll log in with you in a similar format. I would be in your ear during surgery on a Bluetooth headset. We can have an assistant holding any camera of any kind. It could be as simple as your cell phone, and walk you through the procedure step by step. So we plan it in advance, and I'm, in your ear during the surgery, helping you through it. So it's, again, an opportunity to see how we can really bring our global community. I think more than anything else I've learned from this is, one person in Wuhan can literally touch the lives of everybody in the world. And that's, again, unfortunately here in a negative fashion, but in so many positive ways, we can, reach each other in this day and age, through physical travel and through virtual travel, to really help each other out in every way possible. So to take this negative that we've been experiencing and turn it into a great positive, and just see how tight-knit the global community is, I think for me is the biggest lesson for this. So when we have a goal, that goal is going to generally stay the same. How we get there is going to change, and that's change in dentistry in general. We, for many years in dentistry, have looked to both repair our teeth and then looking into replacing teeth. And that's changed greatly over the course of time, with implantology being now the by single best replacement for a missing tooth. Dentures have become much more off to the side. People are doing less and less dentures nowadays, both because of oral care is far better, and implants are there earlier to sustain one missing tooth before the domino effect happens of taking all the teeth down. So the goal is the same. We're looking to get our patients into the optimal health, but the method of getting there will change. So we envisioned the goal first, and then we were going to come up with the best ways to get there. And again, these printers behind me were, science fiction when I started practicing, and now it's everyday practice. These will become obsolete one day too, and we'll move on to bigger and better things. And what I've seen is, over the course of my now 11 years in practice, is that curve is happening much faster with, social learning, as what's going on here online. Things are just done so much faster. Used to be when I would go to a conference and see presenters posting things, and they'll be brand new. In the past, I would say 5 years or so, I'm going to lectures and saying, wow, we've been doing that for already a couple of years. I saw that on Dental Town. I saw that on a Facebook group. We've worked that out all together and come up with a whole new motif of how to do things. And it just moves so much faster. So the global community, again, our means of transferring information to each other, makes things that much easier to get better at things faster. So when we're looking to place an implant in our crown, we need an adequate amount of volume of bone and tissue to serve as the foundation of the implant and crown. So imagine if the bone is our foundation, and then we're going to place an implant to be that platform. We're going to have an abutment or a superstructure of some kind, and then finally our crown on the top. But it all starts with the foundation. So what we're going to focus on today is the foundation of all implantology, which is the human body. The human body, our place of interest specifically is the hard tissue and soft tissue that are going to be around there supporting the implant. So we're going to talk about the very basics on a cellular level, how is that working, and get into the details of your clinical decisions being made on the basic biology that will never change. So the goals of what we do will change, or the goals are going to stay the same. The methods we're going to take are a little bit different, but the biology, as far as I'm aware, hasn't changed from the beginning of man. So biology will stay the same and will react the same way. And we're going to have different methods of how to get biology to help us rather than hurt us, but a basic understanding of how those cells work is critical to understanding. So the goal of an extraction. So the goal of an extraction obviously is to remove the tooth. That we know. That's been done since the beginning of time. It is the oldest dental procedure that's ever been done. Those who have seen Castaway, you can remember, it was one of those movies I was watching with my kids recently. The oldest procedure was the dental extraction, where he performs it on himself with a rock. Not so fun. But again, removing the tooth is going to happen anyway. But our goal is not just to remove the tooth. That's going to happen on the side. The goal of atraumatic extraction is to leave as much scaffolding as possible to be able to allow the bone to regenerate. Let's talk about on a cellular level what is happening. So we have two basic cells at work here. We have the mesenchymal cells, which are found in the stroma of the bone marrow. That's the center, deepest part, most part, the yellowish looking material in the bone marrow. So those cells will differentiate into different kinds of cells. The ones that are most important to us are the osteoblasts. Osteoblasts are the ones that, as it sounds, osteo being bone, blast is a creation. So it's creating the bone cells from these osteoblasts. But the way the human body works is we get a brand new skeleton about every 2 years. So we have the hematopoietic cells, which differentiate into osteoclasts. The osteoclasts are the ones that are eating away at the old bone. So it's a constant back and forth in our body. Osteoblasts are creating new bone. Osteoclasts are removing old bone. And in their wake come the osteoblasts to create new bone. So it's a constant turnover. If that is disrupted in any sort of way, it throws everything off. And what we've seen in the bisphosphonate drugs to try and combat osteoporosis, what's happening is the osteoblasts aren't working quite as well anymore. The osteoclasts are still working, but the osteoblasts aren't working fast enough, and bone density is decreasing. So what happens is the drugs of that have been found nowadays to work are affecting the osteoclasts to slow down. So doctors will tell their patients to get exercise and do things to physically stimulate the osteoblasts to work. But on a drug level, what we're doing today is slowing down the osteoclasts. So when the osteoclasts are slowed down, the whole bone process can start to not work well. And that's what we're seeing in the jawbone with the bronze cases, is where you're having bisphosphonate-related osteonecrosis of the jaw, is when, for some reason, we don't know exactly what happens in the jawbone, but when a surgical procedure is done in the bone, the osteoclasts aren't working fast enough to remove the traumatized bone, and the osteoblasts then are not creating positive bone in its replacement. And then you get this necrosis because the process of regeneration is not happening. But again, it's all going on in this same cellular level, and the same way as a basic socket needs to heal, we take out a tooth, the osteoclasts get to work to remove the old bone, the osteoblasts come in their wake to build new bone. So that's a critical piece of information, and the timeline we're going to discuss is going to be really important to knowing when to treat patients after extractions to the implant to the restoration.
Robert, can I just jump
in? So the osteoclasts, again, cause the bone to resorb as a precursor to remodeling. And that's a electron microscope picture of an osteoclast at work, and the enzymes dissolve the bone on the surface, and the osteoblasts then form them in their wake.
Robert, can I jump in a second?
Yeah, please.
The attendees are saying that they can't see your video feed. Maybe you could try stopping and starting it again and see if we can work that out.
My desktop feed?
No, your desktop is being seen, but your video feed.
My video.
Yeah.
Let's see. I see me.
I actually see you as well, but
let's see.
Stop it and start it again and see if that works it out.
Let's try. Stop video. Okay. Can you see my desktop still?
Yes.
Okay, we're starting video. I'm back on.
Okay. Hopefully that resolved the issue. Okay, now we're getting positive responses. Okay.
Good. Okay. So so the osteoblasts, again, osteoclasts, as we just talked about. Good. This is a slide, again, showing the same idea. So you're seeing, and if you could see my mouse, let's see if you could do this. Can we see my mouse on the screen?
Yeah.
Okay, good. So again, towards the rightmost part of your mouse here, of the screen here, you'll be able to see the osteoclasts working in the front and the osteoblasts in their wake, creating new bone behind it. And this is a tooth erupting. And again, you're going to see that's the same way that orthodontics works. Osteoblasts and osteoclasts. The positive pressure placed on the bone cause the osteoclasts to start working. And then in the wake of that moving tooth will cause the osteoblasts to then form new bone behind it. So much of what we do in dentistry is just these two basic cells. If you understand how that basically works, many of the questions of why and how things work will be answered. And the biology of socket remodeling. So basically we take a tooth out, what happens on the cellular level? So the first day is we're just trying to stop the bleeding. We want a blood clot to form. That's what we tell patients, don't rinse your mouth too much, don't suck on straws, obviously don't smoke. We want things to be able to be in the best healing shape possible. Nowadays, we are putting in bone grafts, which we'll get into, or at the very least, some sort of collagen, something to hold a plug in. I don't remember the last time I took out a tooth and didn't put something inside, something to hold it up. We'll use PRF, we'll use something. We want a clot to form and to be held in place. I'll usually put a couple of chromic gut sutures that will be dissolved in about 7 days, and that will help keep everything very stable inside the socket. And that will, on the flip side, will stop what was historically the biggest complication with extractions, which was dry socket. So I can't say that I've had a dry socket since being in private practice. It may have happened. People have post-op pain, but I've never diagnosed a dry socket per se as saying, yes, this is certainly dry socket, where I look in, the socket is empty, there's exposed bone, there's a certain odor. I remember in residency you would find with cases of dry socket. But since doing grafting or putting collagen or something with a suture, it almost never happens. But again, we're looking just to stop the bleeding. Day 2 to 3, the blood clot is forming. We start getting granulation tissue. Granulation tissue is that white, yellowish, healthy tissue that's starting to form. I got a hand raised in the corner I saw. I don't know if Michael, is there a question associated with that?
No, just a wave, no question.
So wave back at you, okay. So we have blood clot, granulation tissue, we get small blood vessels to start forming. Day 7, which is historically when most people do their first post-op visit, as day 7. So we want to see more granulation tissue, want to start to see connective tissue. Those osteoids are starting to form, and we're starting to see the epithelium. That's that white border around the outside of the socket. You're starting to see that's the early granulation tissue and early epithelium starting to form. So that's what we're looking for at that 7-day post-op. Day 14, we're starting to get more of an abundance of granulation tissue, and epithelium at this point should be completely covered over the wound. And when I got into private practice, I moved away from the 7-day post-op and more into the 14-day post-op. And we'll see, I've even moved into the 4-week post-op, because what would happen is I would see people at day 7 and day 14, and they would sometimes say, I'm still in some pain, it still doesn't feel exactly right, and it doesn't look healed. It still looks like it's healing, but that early phase of healing versus going south and something getting infected can oftentimes look very similar. So it's hard to see the difference clinically. What I'm always looking for is post-op pain to be decreasing. When it's decreasing, I know things are healing well. When I see a sharp increase in post-op pain, I tell people to come in earlier than a 14 or 28-day post-op. About day 20, we start having new blood vessels forming, connective tissue, and the osteoids are starting to mineralize. So now we're talking about actual bone in the earliest stages starting to form. Day 40 is where we start having connective tissue, immature bone, and now significant epithelium over the area. Day 60 is when we're starting to have some mature bone forming, and the keratinized mucosal coverage is now covering over the wound. So this is about our 2-month period, which is the earliest time when people talk about restoring an implant. Not so much from the, it has to have really good primary stability for that to happen, because we're still not over the bell curve of full healing by day 60. The full healing really won't happen for a year to 2 years is when the implant has been fully integrated, but we want it to be strong enough to put a tooth on it. So we need it to be strong enough. So we can sometimes do an Ostel test without moving the implant at all, check it and see if we haven't dropped off too much from our primary stability or started to increase a little bit. We would potentially look at the earliest stages of restoring. But again, that's all the basic biology of socket remodeling is going to have implications for the socket, for the implant down the line, and for the final restoration. And this was first discussed by Amler in a paper he wrote in the late 60s, just describing this process that, again, the oldest procedure we've done in dentistry. He just went day by day and documented exactly what's happening, both on a clinical level and a cellular level, explaining exactly what happens. But again, a simple graphic like this can help us oftentimes make the decisions clinically of when to move forward with the next step of the process.
Can I jump in with some questions that came in?
Yeah, please.
First question, what about bone resorption during these 2 months?
I don't hear you, Michael. Are you speaking?
Yes. What about bone resorption during these 2 months?
Bone resorption. Okay, so bone resorption, you're talking about after the tooth taken out and the bone is resorbing around that socket. So yeah, that absolutely does happen. The same biological process. And we're going to get into the grafting section. We're going to talk about limiting that bone resorption and why that happens. So part of it's due to a blood supply that we're cutting off by removing the tooth. And part of it is just the body is going to try and consolidate the socket as best as possible. Again, the body's trying to use its resources as efficiently as possible. So if the tooth is gone, the body has nothing to hold on to that bone, keeping the same dimension. So it's generally going to try and squeeze it down to be a little bit less and not need all the resources of leaving a larger piece of bone without having the necessity of a tooth. So in bone grafting, what we're doing is trying to keep those plates of bone open and giving a scaffolding for that bone to be able to regrow. If it doesn't, we just take out the tooth, we would see a significant tendency of the bone resorption. But the grafting procedure will help to minimize that resorption.
Okay.
But again, one of the things really important to take away from that study in the 60s wasn't important to him back then, but the same study proves the same thing, is that bone forms much slower than soft tissue. So the idea of membranes, which we'll get into later, is the same idea. Membrane is there to keep the soft tissue out, because if I have a race between my fast healing epithelium, which is our Bugs Bunny, versus our slow healing bone, which is our tortoise, it's going to win every time. Bugs Bunny is going to win every time. So our membrane is there to keep Bugs Bunny back, keep the epithelium out, and allow the bone to heal undisturbed. We need to create a scaffolding around that and just not let the epithelium close in on that spot. So that's the concept. Again, that same study in the 60s, biology doesn't change, gives us our clinical decisions of when to use a membrane and extractions. I'm going to get into some of the details when we get later on in that part of the lecture, but again, that concept is key to understand now.
Okay, what's the difference between
So anatomy of a tooth. Yeah, go ahead.
What's the difference between osteoid and immature bone?
So the osteoids are the first process of immature bone. The more as it becomes mineralized, as time goes on, that's when it becomes more matured bone.
Okay. Does the healing process differ between the mandible and the maxilla?
So on a cellular level, it's not really having any differently, but on the way that the mandible is just a different type of bone, because it has a lot more thick cortical plate than the maxilla does. Maxilla is mostly cancellous, spongier bone, while the mandible is much more cortical, right? You will tend to see less resorption on a mandibular tooth with thick plates of bone on both sides than you will on a maxillary bone. It'll also make a difference based on what areas of the jaw there are. And we're going to get into it very briefly, that the posterior maxilla is different than the anterior maxilla. That posterior mandible is different than the anterior mandible. Dr. Mish has broken up down into 4 different classes of bone. He gave the comparisons to wood and said basically the strongest bone is your posterior mandible. Your then next strongest bone is your anterior mandible. Your anterior maxilla is then the type 3 bone, and then the softest bone, the type 4 bone, is the posterior maxilla. But again, that's there regardless of what area of the cellular activity that's going on. It's just the strength of the cancellous bone versus the cortical bone.
Okay, when do you or do you not use a bone graft? Are you going to discuss that later?
Excellent. Yes, hold the question. It's an excellent one. Just keep the biology in mind, and then when we discuss why we do and why we don't, will make a lot more sense then. So back to the anatomy of a basic tooth. So we all went to dental school. We've done this in great detail, but just again, take a look at the socket as this is a cross section of the tooth. I think it's just very telling. What we can see is on the deeper levels, we have a PDL which is hanging onto this tooth quite a bit. We think of the PDL as a very thin microscopic tissue. It is that, but it's very, very strong as well. It can hang on to this tooth in incredibly strong fashion. And it's also there as a cushion and kind of a protectant against someone getting a major facial trauma to the face. What will happen is the teeth will absorb most of that shock and will be avulsed, but will minimize the amount of jarring effects that will happen to the skull itself. So the body is kind of created to protect the brain, because that's going to be the most important organ of the body, and take a loss at the tooth level. What implants don't have that. And I talk to my patients about the advantages of implants, but one and very few disadvantages of an implant versus a tooth in terms of strength, it'll be stronger because the bone connection to the implant is a metal to bone contact. It's gonna be a much stronger connection. You don't have any mobility to an implant, but you do have some slight mobility to a tooth. That's good in most situations, but if someone has facial trauma with an implant, the tooth is gonna be knocked out and take a big chunk of bone with it. And that full force that hits the tooth will be transferred to the skull. So that is, if someone is involved in contact sports, they would want to wait until they're done with contact sports until they would have their implants done. When I was younger watching hockey, I would always wonder, why are these hockey players who are making millions of dollars wearing flippers on their front teeth? Can't they afford an implant? So the answer is their dentist tells them, team dentist, I guess, would tell them, wait, here's a flipper until you're done playing. When you stop having pucks slapped at your face at 100+ miles an hour, then it's time for the implant. But again, anyone who's involved in mixed martial arts being very popular, boxing, things like that, wait until they're done, realizing that's not a good way to go as you age, until you get the implants done down the line. Good. So we're going to start looking at some CT scans to appreciate some of the anatomy of what's going on. So this is a section basically looking down at the mandible, just to get an idea of what we're looking at. So let's look at, this would be tooth number 30 here. Just zoom in there. So we've got a buccal plate, and you can see how white it is. That's the cortical bone. That's the much thicker, harder bone, versus the lingual plate is much, much thinner for a mandibular tooth. Then we have our interproximal bone, which can be thick, but you can see the darkness of it, which means it's much less dense. So that bone will be much, much softer. So when we're approaching a tooth to remove it, what we want to do is we want to keep the defect within 4 walls. We want the tooth out, but we want to keep the walls in the best way possible, because if those walls are destroyed, the body is going to want to resorb that much, much faster than if those walls are intact. So the way we're going to take this tooth out is to recognize where the strong walls are, use the softer walls to push against this tooth to remove it gently and keep a 4-wall defect intact. And again, we've also got our septal bone. This is then again looking from the front back. This is a anterior maxillary tooth. And again, just to see it now from the coronal section here, just imagine if you're looking again down at that tooth. So we've got a very thin buccal plate for the anterior maxilla. We've got some interproximal bone, and then we also have a very thick palatal bone. So if you're just removing a tooth without regard to where the bone is going to absorb that force, if you just pull on a tooth or try and luxate it back and forth, the path of least resistance is right through the buccal plate. If you take the tooth through the buccal plate, the tooth is out. Again, we've all had times we've taken the tooth out and we're like, oh, that was great. And then we look and it's got a big chunk of bone still attached to it. And then we say, oh no, they have a big defect here. And then if you don't have the training yet to graft those things with membranes properly, they're going to leave the patient with a very large defect. And that, in most cases, could have been avoided if we took out the tooth with respect to the anatomy that's going on. So right now we're just looking at how is the anatomy there, what is a path of least resistance that the tooth wants to leave at, and we're going to then try and take out the tooth the way we want it to come out by preserving the bone around it. Is then a cross section of that same tooth, and again you could just then see and appreciate where that buccal plate versus palatal bone is sitting. And again, if you're going to pull on that tooth, where is it going to go? It's going to go, 98 out of 100 times out the buccal plate. And that's the same view, just showing you the difference between the cortical bone and the cancellous bone. On the buccal plate has little to no cancellous bone at all. Sometimes so much so that when you, in a healthy situation, a person already has a bony dehiscence especially true if they've had some significant ortho done that's needed to pull those teeth much more anterior. That will oftentimes, in a healthy situation, bring the roots of the teeth through the bone, so much so that when you take the tooth out, you already have a dehiscence. So if you understand that beforehand, you can then know to effectively treat implant it. And again, make sure that tooth is taken out, and those usually are in the high smile line patients where the aesthetic demand is going to be very high. And when you take the tooth out, you necessarily are going to have gingival recession, because the gingiva has been sitting right up against the cementum of that root. And as soon as that root is removed, it's lost its blood supply. So it will, by definition, always recede back up. So we're going to want to plan for countering that surgically to give more tissue and a bony support underneath that tissue to compensate for it. But again, you have to know that going in, and it's much easier to preserve a socket as soon as you take a tooth out and to build a socket back up after it's been destroyed. And we'll oftentimes see that if someone has had trauma and treated by either a hospital or otherwise a quick emergency dentist who will just be there to get them out of emergency pain, take the teeth out that have been traumatized, and leave them massive defects. And those, in my history, have been some of the most difficult cases to treat, because now you have a lot of scar tissue and things built up over a large defect of bone. To get it to rebuild, oftentimes will take more than one procedure, sometimes 2 or 3, to get it to fully rebuild. Where if it was done properly the first day of trauma, it could have been treated a whole different way and done in much less time with much better results. So a little bit of history of dental extractions. So this is the first dental instrument in modern history. It was called a dental pelican. It was used between the 14th and 18th centuries. So just to appreciate, again, the different times we're living in, they sat for 400 years using this, what we look at as, dirty, rusty, archaic tool that I'm sure was never cleaned between patients because they had no idea of what was going on in the blood. They certainly had no concept of bacteria versus viruses. But for 400 years, they sat with that same tool before they even came up with the next one. And we're moving at such a rapid pace that when I went to dental school to now is like light years apart. So just to appreciate modern medicine and the world we live in today, information travels a lot faster for humanity's benefit. This was the surgeon who came up with it. This is a surgeon who does not know his anatomy. Is like a blind man carving a log. This was back when surgeons were also dentists. This was back when I'm sure we've all had that someone will see a physician for a major high fever and abscess, and the physician says, I don't see anything wrong. I look in their throat and there's nothing wrong, and they've missed the massively carious number 19 with a that's obviously causing the whole problem, but because they're taught look right past the teeth into the back of the throat. This is back when physicians also looked at teeth. The next instrument was called the dental key. This is really nice instrument, different versions of it for different areas of the mouth. But the concept was, again, a really good idea. They were looking to get a person with an acute infection to get the tooth out without local anesthetic. So how are you going to get that as effectively possible and done in as fast a manner as possible? So the way these were designed were, again, understanding the anatomy of what is the thinnest plate of bone to remove it, and they would then have this key twist the tooth out in that direction. So crack the plate, get the tooth out, let the infection drain, and let the patient live. Nowadays, we would think of it in the completely opposite direction. Again, our goal is to get the tooth out, but our main objective is down the line to get this person a tooth replacement. So we don't want to rip the tooth out through the plate, but that was their intention back then. And again, our goals are somewhat different. So you never knock what they did in the past. It was a very effective treatment for what they needed, but our needs have changed. Then came into the dental forceps age. And this has been going on since I think the early 1900s, when they transferred over from the dental key to the forceps. And these sat in dentistry for a really long time as well. And I call it the modern era because this was the dental school book, the oral surgery book I used in dental school in 2008. And this is how we were taught to extract teeth. We would place the forceps on the tooth. We would luxate back and forth to try and shake that PDL and loosen it somewhat. Shake back, shake forth, and then deliver the tooth. And when it comes out, great. It's beautiful when it comes out that way. And when the bone stays intact all around the socket, that's great. But as we all know, when we take out teeth that way, more often than not, I would say, a big chunk of bone is coming off with it. And again, the path of least resistance, that weakest point of the bone, is usually going to be what breaks to come off. So then we got into the era of elevators, which was a tool to help use with the forceps to start to loosen the PDL from the socket. So we were taught to create a purchase point in the tooth, and that would allow the elevator to grab onto that tooth and start to have much more force from the inside to pull up. So although it's less traumatic than luxating per se, but again, it's putting a lot of force on that pivot point on the bone, and also has a high chance of, when you're just pulling on this PDL, it's going to take some bone with it. The thinnest bone is going to come out with it. So atraumatic extraction looks at it differently and said, okay, we know the tooth needs to come out. We know that's going to happen anyway. We know that if we take off chunks of bone when we do that, we have a much more difficult time getting implants in later, because we're leaving ourselves with large defects. So how do we more intelligently remove these teeth for our purposes? So we started to look on a ligament level, what's going on. So there's 13 different connective tissue fibers surrounding a tooth, and they all have names, and we took a test in our first, Perio 101. But the names here are less important than what they're doing. It's 13 different very strong fibers. 6 of them connect directly into the cementum of a tooth. And in the Perio book, it shows them like these little wispy lines that if you breathe on them, they'll break. And we were always careful when we're probing to be very gentle, not to push into the biological width space and not to sound down to bone, because that's going to open up an area for bacteria. And that's all true. But then to get to the deeper periodontal ligament is a much firmer ligament. And again, these ligaments, this is under an electron microscope, again, are very thick, elastic, very strong piece of tissue. And we all know that because we've all had teeth that are really difficult to come out, even though on a bony level, it looks like the tooth should come out very, very easily, but on a ligament level, that ligament is really hanging out for dear life. And it's a bone to tooth connection that's usually going to win if that bone is really thin. So how are we going to remove this tooth and not take bone with it? So the idea is to have that ligament let go of the bone and not bring it with it. So first we're going to start with a circular incision all around the tooth. So we want to, in the very early stages, just start to cut away at that ligament, push into the space, and cut. This is just sounding down to bone and a little bit past it. The earliest days we were using scalpels to do this, but now using periotomes, which again are just very thin instruments, and you're pressing very firmly into the PDL and then past the PDL to the bone level and then into the PDL space. And you want to press it so hard that if you can let go of the instrument, it will still stay there. Once you press it that hard, you've gone far enough for now. And then you'll move on to a different part of the tooth. So I usually start in the mesial, move to the distal, go to the buccal, go to the lingual. Then I'll go back to the mesial, and I'm able to get that instrument even further down than I was before. And what that's happening is starting to press down into this tooth space, cut the ligaments, and cause blood to start to flow down into that socket. And that blood flow is going to help us also because it's going to create a hydraulic pressure from the way up and start to push on the tooth on the way out as well. We're also going to section teeth. And I know a lot of dentists look at sectioning teeth and say, it's not what I really like to do. But if you've got a multi-rooted tooth, it's nearly impossible to get that multi-rooted tooth out without sectioning it effectively. So if you section a tooth, you can get to the PDL, again, at 360 degrees, and we treat each root separately. So we're going to use our instruments pushing into that PDL space on each root, and then take out each root individually. If it's a multi-rooted tooth, it's going to design to anchor its way in. So by not sectioning it, the likelihood of taking bone out with the tooth is very, very high. So it's rare that I'll have a tooth taken out, multi-rooted tooth taken out without sectioning it. And even a single-rooted tooth, in many cases, I will still section, and I'll talk about that in a minute. Let's first look at our molar. That's where, if you're getting into implantology, do the molars first. And the reason why is because it's the least demanding in terms of making sure everything needs to go exactly right. it is still very demanding. I mean, there's a lot you need to know that goes into getting a single implant in, but the threshold of need for it to be exactly as you wanted it to be, to go from a success to a failure, is the threshold is much lower in the back of the mouth. So that's your better place to stay. So we're going to want to take this tooth out. We're going to want to section it, because again, this root, with the curvature the way it is just not going to want to go out in one piece. But if I section it down the middle and take out the distal root, and now I have room to push the mesial root into that space, I may push into the septum and take that septum out, and we'll talk about when the tooth is out what we do with the septum, but that's totally fine. I can live with that very well. But if I try and pull the tooth out as one unit, I'm going to end up taking bone with it. And again, in a maxillary anterior tooth, I will oftentimes section also. If it starts to give me trouble, or I will put very firm finger pressure on the buccal plate, because we saw how thin that is. And if I start to feel pressure that the tooth wants to deliver through that buccal plate, I will not allow it to do that. I will rather section it, create space in between our cone-shaped root. I'm going to section it in half. So what that does is I now have space between the two sides. So once I have space between the two sides, I have room to push with my instrument on the mesial, on the distal, and it's got room to push in. If I'm just working on a cone-shaped root and I don't have a section through it, it's got nowhere to go. And the teeth are right next to each other, and the septal bone between the teeth are also very thin. And if we damage that bone, we also will have the papilla start to recede. So on an anterior tooth with especially thin bone, and especially true on a thin biotype of tissue, meaning the tissue itself, sometimes it looks like tissue paper, you're going to have a ton of recession there. So you want to keep things as pristine as possible. So I'll section the anterior tooth in order to create space. That space, again, push from the mesial, push from the distal, allow it to collapse in on itself. Once I get one piece out, I've got plenty of room to push that rest of that root into its space, and then that will come out as well, and leaving the socket itself as pristine as possible. And again, this is pushing in from the distal once I have space, pushing in from the mesial, and what we're trying to avoid is this. Because this happens, we are in trouble. To rebuild this is going to be very, very difficult and very unpredictable. Meaning, can it happen? Sure. If someone comes in and has had this trauma happen, can we try and rebuild it? Absolutely. And we will do it, and we have a lot of steps and methods to do it. But how predictable is it? Much less so than taking the tooth out properly. So what we're trying to do is create a wedge. And again, the wedge is the length to thickness ratio. We're trying to push into that socket. That force of our instrument pushing into the PDL space is going to push in both directions. That's going to start to sever the ligaments apart and have them let go. And if you've done extractions with elevators, you know that you sometimes will start elevating into the PDL space, and then you just feel a pop. That pop is the last parts of the ligament just letting go, because they've had too much force put on them for too much time. So the way we're going to do that is create every situation to allow that popping sensation to happen, and have the tooth let go of the bone rather than forcing it out with forceps. And we use that with progressively thicker instruments. I'm just showing here a couple of instruments. These are Carl Schumacher. They make a great kit called the Proximator kit, which is one of my favorites. But you can find similar instruments. I've seen people get them on eBay. They're not as sharp and they're not quite as good, but they're a great start. So without spending a few $1,000s right away on the top of the line instruments, you can get an eBay Proximator kit and just get started with that. And once you see how much you like it, and you do a lot more of it, then you can move into something, a higher quality instrument that's just going to last you longer and be a little bit more effective. But the idea is we take the Periotome, which is these guys, very thin blades. They have different angles. So one side is going to get you your proximal sites. The other side is going to be easier, without moving your hand too much, get you onto your buccal and lingual sides as well. We then move into thicker instruments, and then eventually into the thickest of instruments. And we've got many more in between these. I'm just trying to show these to show what we're doing is the wedge effect is going from very, very thin to a little thicker, a little thicker, a little thicker, until the tooth pops out. Usually I'll have it out in 2 or 3 instruments. It doesn't take us to getting into these elevators till I have the tooth out. If we push into the PDL effectively, it will come out much, much earlier than that. Again, just showing the difference between the thinnest versus the thickest and steps in between that. So again, we're going to move in from on the mesial first. This is on a maxillary premolar, which is also a really good place to start. And we're going to press the instrument in until it sticks there. So you can actually let go of the instrument and it will stay in the place. That's how you know you've gotten deep enough and you have enough of a wedge going in. And you'll leave it there for about 20 or 30 seconds. That doesn't sound like a long time, but when you're used to moving in dentistry, and we all are, that can seem like an eternity. But we want to work smarter, not harder, right? So when we place the instrument, let the instrument work. What it's doing is what's called in physics the creep effect. It's the slow deformation over time. So the instrument goes in, it's starting to stretch the ligament out. If we take it out too early, we haven't let it do its job. So leave it there for 20 or 30 seconds. We'll then start to rotate it and even get even more of an effect there. You'll then notice that you can drive the instrument now deeper than you could have before. The reason is the PDL towards the most coronal part is starting to tear. And now we're able to move even further down. Do that again, push it a little bit further, leave it in for 10, 15, 20 seconds again, rotate again. We're not looking to get the tooth out with one shot. We then go on to the distal side and we'll do the same thing. Again, that's that creep effect, material change over time under the constant load. You have to keep the instrument there for that constant load to work. Rotate it back and forth, and that creates a class 1 lever. What's happening inside the socket is that we've got this PDL, which is now filling with blood. Again, as that PDL fills with blood, it is using hydrostatic pressure to push the tooth already out. So it's working along with it. So this is a time-sensitive project. You have to give it time for it to work well. You're just looking to get done fast, you're going to be very frustrated with this procedure. That's why I suggest people, if you haven't yet done extractions this way, schedule yourself double the amount of time, if not more, to get used to it. Because otherwise, if you've got another patient breathing down your neck, you're going to want to get the tooth out faster. You'll grab the forceps, you'll rip the tooth out. It'll come out, but you'll often have bone along with it. And again, we're in a slower period as we come out of this virus time. So fortunately, unfortunately, we'll have some time in our hands. So schedule these patients appropriately. And again, use the time to educate yourself during this time. We then move to the other side, place the instrument, 20 or 30 seconds, rotate. And again, now we've got blood filling the other side. So it's working every step of the way. It's working harder and harder. And if you left the room at this point, as they saw another patient, did another exam, came back, the tooth is going to be significantly looser than it was when you left. I don't suggest doing that. Stay with your patient, finish the procedure, get the next thicker instrument, and keep going. But it takes time. And then again, that pop we talked about is when you're going to rotate that instrument and the tooth is just going to pop right out. And that's when you know you have it. And again, it may take 2 or 3 instruments. I would say for me, that's about average. May take a couple of more. And you'll realize after you do this a few times, inevitably, you're going to take the instrument out too early. You're not going to give it the full 30 seconds. And you'll realize after doing that a few times, if you just left the instrument in for longer, you would have been done faster. So it's, again, working smarter, not harder. You're going to, again, drive it as firmly apically as you can. And again, I have my patient oftentimes has a pillow on the back of their, behind their headrest. And when I'm pushing, it's really some very significant pressure. They're totally numb. They feel no pain, but it's a lot of pressure going in. I'll tell them that before we start. They're going to feel a lot of pressure, and you'll see their head depress further into that pillow. That's how you know you're putting an adequate amount of pressure on. Again, for maxillary tooth, mandible, you'll want to support their jaw well. So when you're pushing down, you're not going to put too much stress on their joints. Okay, we talked about using progressively thicker wedged instruments into that PDL space. And the only time I'm going to, in a month, I'll pick up a forceps a couple of times. And it's only when the tooth is out of the socket per se, but you've got still some soft tissue holding onto it. I'll grab a forceps and just rotate off that soft tissue and let it come out. But I'll never put force with a forceps onto the bone to get it out. So again, luxation, which you were taught, and almost all of us were taught in dental school, is our primary force to remove a tooth. I want you to forget that. Luxation is really a very outdated way to remove teeth. Again, if your plan is to get an implant in there or preserve the bone for anything. And again, even if they're going to get a RPD down the road, you want as much support as possible to leave the bone there. So the more bone you leave there and the better shape you leave the bone, the better the bone will heal, even if you don't graft. And we'll get into the grafting section in a little bit. Just checking our time. We got about 5 minutes left to show you just a couple of cases here. So this is when the tooth is then removed. So on a cellular level, for bone to heal, you need all the soft tissue removed. So you're gonna wanna really get a sharp spoon and scrape away on the inside of there. I oftentimes will use a handpiece on a surgical handpiece. I will use like a carbide red striped football board is one of my favorite ones on a surgical length. And it gets into the socket, and it's the difference between, you know, shoveling with a spoon versus using a snowblower on a handpiece. And it just flushes water in the socket, takes up all the PDL very quickly. I'll check it again with a spoon just to make sure I got everything, but you want to make sure every bit of that PDL is removed, because if PDL is not removed, it will impede the bone growing around that space. That's a critically important point. So you want it to look pristine. So just look at the difference between what a socket looks like here versus here. And if it's in the posterior of the mouth, I'm going to want to remove all the coal. That's that interproximal tissue. On the anterior, definitely not, because the papilla is aesthetically very important. But I want to remove all the cola tissue also to make sure I have a really solid four-wall defect, and I want to see nice bleeding bone on the inside. If it's not bleeding, again, you're never going to start that osteoblast, osteoclast process from happening, and your chances of having a dry socket are pretty high. So you want to make sure to get in there and use that burr and start to even push into the walls a little bit until you see the bone start to bleed. When the patient leaves, you want positive hemostasis, but you want not because they weren't bleeding to begin with. You want to make sure that the bleeding is a healthy, good bleed, and then stop it. And again, you want to remove certainly all the granulomatous tissue. That's the unhealthy, infected tissue that was there. All the pus, all the any sick tissue that was in there. Make sure that's all removed. But even the healthy PDL, that also has to be removed for ideal healing. To show you a case here, this was a 32-year-old male, chronically infected, number 19, and a poor number 18 with furcal involvement already. And again, when you see the dark area in the furcation here, this tooth is a matter of time. And if it has mobility, even more so. So, you see some darkness all around here. You want to be really, really careful when you're grafting and when you're placing implants to make sure the adjacent teeth do not have periapical lesions, even if they're asymptomatic. And I've learned this the hard way too many times early in my career, is you don't want to push them for the endo on that tooth because it has no symptoms. And then you put the implant in, it'll get infected almost every time, because we think of two teeth being as like their own little compartments, and one bone sits in one socket, one tooth sits in the other socket, and the two don't meet each other. As we learned from viruses, that's not how it works. We learned from teeth, that's not how it works. Bone is like a sponge in between. So the infection that's sitting around one tooth, that bacteria will very easily grab onto a freshly placed graft or a freshly placed implant and will infect the entire area. So, and again, it may not even be symptomatic. I will oftentimes see, they'll come back in, let's say, 3 months when I'm ready to put the implant in, and I see the graft just looks unhealthy, just looks like it's not fully healed. It looks like there's a dark area around it. It doesn't look like it's integrated bone. And I'll go in and I'll open it up, and it's just mushy, just unhealthy graft that's been encapsulated. And the reason why is there's bacteria there. The bacteria inhibits the healing process around it and is growing around the implant, around the graft or the implant, and you'll just not get good growth. So make sure the adjacent teeth are always healthy before doing the grafting procedure. If the tooth needs an endo, do the endo. If it's asymptomatic, but you see an apical lesion there, especially in a CT scan, it can be very clear. Make sure to do that prior to your treatment or in conjunction with it. If I'll do, let's say it was an emergency extraction, and then the tooth behind it needs endo, I haven't done endo since residency, so I'm not interested. I'll send it to my excellent endodontic colleagues in my area, and they'll take care of it, but it must be treated. You can't ignore it. And again, we're going to sulcular incision with, this was back in the day where I was using blades, and I leave this here just to show you, you don't have to go out and buy fancy equipment. You can use what you have in the office already, and then when you get good at it and understand it, then the better instruments will help that process along. And again, sulcular incision all around. I'm going to start using these instruments to press into the PDL space. I'm going to be working basically the corners from the mesial distal to the mesial buccal, to the mesial lingual, to the distal lingual, to the distal buccal. All 4 areas press firmly into the PDL space. And then I'm going to come in and section the tooth. I am going to section again both teeth, and I'm going to put pressure now from the center of the tooth as well. I'm not just working on the mesial and distal, I'm also working the center in to remove the PDL from each of those roots. Pressing into those spaces, and again, using progressively larger instruments to press in. I'll say nowadays, I rarely even get to this size instrument. I usually have a tooth out before then because I'm much more efficient with using the smaller instruments. And then again, the tooth pops out of the socket. Once it's popped out of the socket to this degree is when I'll pick up forceps just to rotate the soft tissue off of it and pull it out that way. Then I have, once the first root is removed, and then harder to remove teeth, this is really important idea. Once you get one piece out, you now have a ton of room to press the other piece into. So even if it's a tooth and you, let's say, even broke a root tip off, which doing it this way rarely happens because you're not putting pressure from the sides, you're putting pressure from the top down. So rarely are we breaking root tips out. Happens still sometimes, on especially endo teeth, it does happen, but it's really I would say a handful of times a year it'll have a root tip broken on the bottom. But once we have one piece out, we have a lot more room to push the other piece of the tooth into. And that PDL will get stretched out and can easily be removed. Once it's mobile to that point is when we'll rotate it out with the forceps. I also have these root forceps, which are just a much thinner forceps to get much deeper in. So once it's moving around, I can grab onto it and rotate it out of that socket with a thin instrument. Then I'll take a spoon and start to clean out everything that's in there. This tooth obviously was a mess. These couple of teeth were a mess. Use a rongeur to remove any granulomatous tissue. And then we'll take one of these burrs. This is a carbide. I usually nowadays use the red striped carbide. It's a little bit finer. It's fine to the point where if you go into a socket and just gently rotate around the socket, it's enough that it'll pull off the PDL very quickly and efficiently, but not so much that it'll gouge out the bone unless you press and really lean into it. So it's a very effective too. This is a non-surgical length. This is the same one you'd use for polishing the lingual of an incisor, but they make surgical length ones as well, which is what I use today. And go into the socket as deep as you can. Again, with a smaller burr, you're going to be limited. With a surgical length burr, you'll have much more space to get into. This is we're going to talk about grafting in the next section, which at this point is going to probably be the next time. But anything to get into this area is going to help it hold on to the scaffolding. So a piece of collagen will be great. This material is called foundation, which is a heat-treated collagen, which will just slowly dissolve in the socket, but will hold it there for a long time. It looks just like a collagen pellet. It fits in, and it kind of, as soon as it gets wet with blood, it'll kind of meld into the area. And a couple of sutures there just to hold it shut. I keep these older slides. Very tempted many times to change them, but I don't ever want to do a procedure again where I'm using a operative handpiece to clean out a socket, because it's something we call a subcutaneous emphysema. And it's just important to know as you're going to be starting surgeries, what could happen. So subcutaneous emphysema is a collection of air in the subcutaneous tissue. We did it in just a couple of minutes. Sorry for running a bit over. It's pretty rare, which is why people don't know about this, that you would never do this, but it still does happen. Anytime I give one of these courses, I'll ask anyone if they've ever had this happen, and almost invariably, a couple of people raise their hand. I guess we have a hand-raising tool here. Has anyone had this happen in their practice? Any hand waves? Yeah, there we go. 2, 5, 8. Okay, we've got 7 hands raised out of the 210 of us. So it's happened. So if you are one of the other 203 people saying you've never heard of this before, it does happen. It's a painless swelling of the face and neck, and it is an immediate onset. There's crepitus of the tissue, which is basically you push on it and you'll hear like little popping, like snap, crackle, pop noises. It's an immediate onset, so it's not something that you can think, oh, did that happen, did it not? Oh, you'll know, because it'll look like this in a minor case, which is just an air pocket trapped. And again, they don't know about it, but it can look scary. It can look scary like this sometimes, and this is a very significant case where a person had to be admitted to the hospital because it started causing airway issues. Usually it's not dangerous, it's just freakish looking. People will tell me it looks like a watermelon sometimes on the side of their face, or a grapefruit, or name your large fruit on the side of the face that shouldn't be there, but that's what it'll be. All in a very preventable situation by not forcing air into subcutaneous spaces. So use a 45-degree handpiece. with a rear vent. And again, those surgical handpieces are good for two reasons. One is you have much better angulation to get into the posterior of the mouth. Second is they push air backwards. So it will not have forcing air into that space that could cause one of these emphysemas. Electric handpiece works really well also. If you have an electric handpiece, they're fantastic for sectioning teeth because the torque on them is remarkable. So they can cut through teeth really like butter. But there's the chip blower, which is there to kind of force air when you're doing restorative dentistry. You want to get rid of decay. You want air to push, so it still will allow it to do that, but obviously turn that function off when you're doing surgery. So again, the atraumatic approach is push, don't pull. Separate the tooth's connection to the socket at the concept, create a clear path to draw, and remove inner proximal bone if necessary to create that four-wall defect. Section your teeth, really important. And you want a socket to look like this when you're done, where it's pristine. The bone is just as it was before we started, except the tooth is missing. And you see just that's my section line down here where I cut into the bone a little bit, but that's going to heal up without a problem. And this scaffolding around, I have 3 small holes to fill. And if I wanted to, in a case like this, if the sinus was not right in the place, I've got a piece of bone to place the implant into right away, if I so choose. So it leaves you that possibility to do as well. Remember your anatomy. Remember which areas are thin, which areas are thick. Keep finger pressure on the socket to know if the tooth is on its way out through a thin plate. Don't push it that direction. Rather remove it the way you want it to. Remember the blood supply to the teeth. When we're taking out the tooth, we're removing much of the blood supply. Removing the PDL, we're removing the bone marrow. No longer, the PDL is gone, the bone marrow still has some area. The third thing we have is periosteum. And this is the idea of laying flaps when we take out teeth. We want to get to a point where we're not laying flaps, because when we lay flaps, 80% of the arterial blood flow comes from the periosteum. So when you remove the periosteum by laying a flap, you, by definition, have cut off the blood supply for several days until it can start to come back. So you've cut off oxygen from that bone for several days. That will always cause loss of thickness of bone. So we want to get to a point where we are not laying flaps, but if you have an area where you've blown out a buccal plate, or the tooth, for whatever reason, needed to have a flap laid to get the tooth out, do it, but realize there's a cost. Like everything else, we need a tooth out and we need it clean. Those are the 2 most important things. After that, we want to try and take it out without laying a flap as well. Again, it takes longer than a traditional forceps. Inform the patients of its benefits, that we're going to be here for a little while. You have to charge accordingly because it's going to take you some more time. Again, if your time is less valuable when we first get back because we have an open schedule, just get good at this procedure. But inform them of the benefits. You set your fees accordingly, but oftentimes if you're going to be doing a graft, you're going to make up the fees for your extra time on the graft, which doesn't take a long time. It just costs some materials. And we'll talk about that in our next section as well. But make sure that you're setting your fees for your time in your chair being efficient, that you're not wasting time doing something slower than you were already. You're doing things more efficiently than you were already, taking a longer time for this procedure, but your implant will be far easier and far more predictable by doing so. You have to have practice, patience, and more practice. The more you do this, the better you will get at it. And again, you kind of feel like you did something when you take out a tooth this way. This one's not sectioned. I should show 2 pieces, like Moses coming down with 2 tablets of the tooth. But the idea is that it's a different feeling of accomplishment when you take out a tooth and the socket is in pristine condition. So that takes us through our hour. We will get into our next section, into grafting, into all the sorts of different kinds of grafts, cost effectiveness of different grafts, when to graft, when not to graft. We'll get into all those details in our next session, which I believe Michael is scheduled for next week.
I believe
Tuesday,
on
Wednesday?
Tuesday. Yes.
Tuesday. Next week, Tuesday.
We have Dr.
If there are any questions, I'm certainly happy to hang around and discuss. I don't know how this works. Can we get other cameras involved and other audios involved? Or does everything have to be typed in?
Everything's been typed in. There's a list of questions waiting for you. I don't know if you could pull them up.
Let's do it. So whoever has patients waiting, or if you're at home and kids waiting and spouses waiting, thank you for coming, and you'll get you your CE. But if you'd like to stick around and just hang out and chat, I'm here for a while, so happy to discuss. Okay, so let's shoot. Michael, first question.
Are you able to pull up the QA list? I'll read them out to you.
Let's see. Oh, Q&A. Okay, here we go. Q&A. Avri Lev, we've never met in person, but I've seen yourself on Facebook. Excellent practitioner. If you don't put some substitute in the socket, you actually lose bone height and width. Yes, I agree. I think it's more of a statement than a question. Or was it a question? So if you don't put some substitute in the socket, you actually lose bone height and width. Yes, that will happen. Bone height will probably happen anyway to some degree, but bone width is what we're more concerned about rebuilding. And we'll talk about the steps in the next section of grafting to minimize that as much as possible. Next question, coming from Vlad. What is the difference between osteocytes and osteoclasts? I think we already answered that, I believe. Again, it's just the more mature levels, more mineralized bone. Dr. Singh asks, what are your thoughts on the partial extraction technique? Excellent question. Excellent question. So I was a very, very skeptical of it when it first was being discussed by the Salama group in Atlanta. I thought the concept of leaving a piece of tooth is destined to cause massive failures in not the short term, but in the long term. I'm glad that it was proven incorrect, and they're showing 10-year studies now on maintenance of bone levels, and they're phenomenal. I've got right a few blocks from my office is Isaac Tawil, who's a fantastic practitioner and lectures, one of the biggest lecturers on this. And I was recently chatting with him about this technique, and he's a big proponent of it. And he said it was really technically sensitive early on, but they have come out with kits to make it much, much easier. So I have not done one to date, but I think in this 2020, I will be doing a couple of them and see how they come out. I'll document them well, and we'll be presenting them to see my own studies. But in cases of significant loss of bone, again, we showed like those dehiscence cases. If you could leave that buccal bone there and allow that to heal with the buccal bone not being touched, that means you will never lose the architecture of that buccal plate. So that is an ideal situation to do it. Again, I'm not going to do it in a high aesthetic demand case right away, because my first case will not go as well as Dr. Salama's 1000th case. But I'll start it earlier on in the posterior, get good at it, and then transfer it over to the anterior. But it looks very promising by the research. Again, the concept to me was scary, but the research, again, I'm glad to be proven wrong with a good technique. Can you relate to, next question is, can you relate to if you are going to do socket preservation, even if the tooth is contaminated with an abscess at the apex? Yes. So the answer is, if you clean it out really well, and in my experience, that's the most important part. You got to really get into this socket and flush it out, clean it out really well with hand instruments, with a high-speed instrument. And if it's pristinely clean on a macro level, I will still place my grafts and membranes and have them on antibiotics afterwards. So any remaining microscopic bacteria will be addressed through that. It won't have a chance to grow on my grafts. I know some people will place antibiotics in their graft itself. I've never done it, but if it certainly is prudent. I've just never seen a need for it. So the answer in short is yes, I will still do it in cases, but as with a seemingly healthy tooth as well as a acutely abscessed tooth, it has to be clean. I don't like to take out abscessed teeth if they're acutely infected. I would much rather put a patient on antibiotics for about 3 to 5 days beforehand, for 2 reasons. One, my socket will be much cleaner afterwards. 2, and I'm sure we've all had this experience, is that acutely infected teeth do not get numb well. So I tell patients, if you're in so much pain that pain medication is not helping, and you're going to be in agony for the next 24 hours until the antibiotic starts to help you, we'll take out the tooth today, but it's not going to be fun. You're going to have more short-term pain and longer-term relief, as opposed to it'll be longer relief, but less acute pain if we take it out later. So again, I'll do it when I need to, but again, I'd much rather put them on antibiotics for a couple of days first which actually now, just to bring us back into the corona age we're in, you know, the CDC and American Dental Association are suggesting that we see emergency patients only. And I know a lot of doctors are concerned, rightly so, for being in the office at all and exposing themselves, their staff, and other patients to potential infection. So what I'm doing is I'm doing consults with new patients via Zoom, where I'll see them, have a conversation, and I will try and delay seeing them until things have calmed down a little bit. So I'll give them antibiotics, but again, if it's an acute issue, we'll see them. Doors are open. We're still seeing patients with a skeleton staff, and we're always careful with infection control. But now we're not even having 2 patients in the waiting room at the same time. If we're going to schedule people throughout the day, they're staggered by enough time to finish the procedure, turn over the room, have the patient leave the office. We will then spray down all surfaces in our waiting room, and anything that could have possibly been touched, the bathroom, everything that could have been touched will be sprayed down again, and then the next patient will be admitted into the office after that. So, and I tell people, you may be waiting outside the office for a little bit. We haven't yet had that happen. We've been efficient or scheduled people far enough that it hasn't happened. But yeah, that's the long and short answer to that. Okay, next we have, do you have any criteria to choose if you should go mesial distal way or buccal lingual way? Yes, it depends on the tooth. So my posterior teeth, I'm going to want to, I have thicker bone on the buccal lingual direction, and my anterior teeth have much thinner bone on the buccal lingual direction. So I want to be careful not to push on those areas. So let's go back to our mandibular molar. So I have a thin lingual plate and a thick buccal plate. So if I put luxation pressure, I have a chance of breaking the lingual plate, which is a mess because you've got a lingual nerve and artery running through there, and that could cause significant damage. So you don't want to do that. I'd rather section, again, I'm working from the coronal aspect down into the PDL to force it out more that way. So I'm not really leaning buccal lingual mesial distal, but once I'm pushing down, I'm going to push into the areas which not pushing into the weakest point possible. So I'm going to put my finger on the lingual plate of that first molar, that mandibular first molar. Make sure I'm not putting too much pressure in that direction, and you'll feel when you push with that instrument, if it's pushing too much on that lingual plate, you'll feel it. It's still pretty rare to break a lingual plate, even if you weren't paying attention, but that's very true on the anterior of both the maxilla and the mandible. Firm pressure on the buccal aspects, because that's very, very thin, to make sure that you're not pushing too hard out, and just pushing pressure in every other direction that will not, you're going apical, but you're also pushing obviously in one direction or another based on which area of the socket you're going into. If I'm in the mesial part of the socket, it's putting pressure on the distal part of the socket. If I'm coming to the buccal part of the socket, it's going to put pressure on the paddle part of the socket. So always know where your counter pressure is going to be and allow the bone to be strong there, and make sure you're not pushing so hard that you're going to break through it. Okay, we've got when you're sectioning the anterior teeth, how far apical are you sectioning? Good question. So if I could go to the apex, great, but oftentimes the apex, especially in the maxillary central, is going to be right up against the buccal plate. So if I go through it, I've perfed the buccal plate through the apex. So I don't want to do that. So in those cases, I'll go about 2/3 of the way down, and again, I'm just breaking off a piece there. And now let's say I broke off the distal part of the tooth. I then put an instrument on the mesial part of the socket, and I've got room to push that root into, and then it delivers out through that space. That makes sense. So I'm going down, again, about 2/3 of the way down the anterior tooth. And a lot of rotational forces are helpful as well. If you're pushing and it feels like it's moving, but it's not all the way out, I'll sometimes then also pick up a forceps, no luxational forces, but I'll put like a small rotational force, and sometimes they'll just rotate right out and pop out that way. But again, never putting pressure on that plate and making sure with your finger that you're not doing so. Any Periotome kits that you particularly like? Yes, the one that I use the most is from Carl Schumacher, their approximator kit. It's excellent. I've been using that for years, and they're workhorses. They will. I've had the one that I bought when I started private practice, and I still use that one all the time. I've added a couple, but I still use that one. Schumacher will also sharpen your instruments for you. I believe they have a lifetime warranty. So you can send them back and have them sharpened, and I'll do like right now. It's a great time. Or the office is slow. So we'll send usually we'll do it before our vacation. We'll ship them out to Schumacher if they got a little bit dull, and they'll ship them back to us, sharpened and beautiful. So Carl Schumacher is my #1 selection. But again, when finances are tight, don't go out and buy the fanciest instruments. We'll talk later on about, if you're getting into implants, where to invest your money most wisely. So I would start off with literally go onto eBay. I've had many doctors do this. Type in Proximator, you'll find a kit for $50 and buy that and get started. It won't be as sharp, but it'll still work. Okay, we've got Vlad here asks, one colleague suggested if the tooth doesn't want to come out, they never do, rather leave it in so the blood accumulation and the inflammation build up and do the extraction 1 week later. I tried twice and it seemed to work. So again, that will work. I talked about putting pressure into the socket, letting the PDL stretch out, taking a 5-minute break and coming back. I've never given a 2-week break, but in theory it will work. I just think the patient will be in some discomfort during that time, be like going through an extraction twice. We do that with endo. Sometimes we give it 2 visits to let the infection clear, but I don't think it's necessary with this. If you're doing this method effectively, you shouldn't need to give it a 2nd visit to come out. But again, if you couldn't get the tooth out, I wouldn't then revert to pulling it out with a forceps and breaking all the bone around it. I would rather start to section and trough, take a high speed with a surgical length thin burr, and we'll talk about this later on, and start to trephine around the tooth. So you're actually going into the PDL space, pushing down with the burr kind of until you feel it's snug, and then you step on the rheostat and let it spin, and you're just trephining the tooth out that way to cut the PDL physically, not just stretch it out. That way will also work. You're doing a little bit more damage to the bone, but you're keeping it within a four-wall defect. Why remove the Paul Springs? Hey, Paul, how are you? If you're still online, long time. Hope all is well. Why remove all the coal in the posterior? So again, we want to get all the tissue away. You'll see in the next section when the soft tissue is healing on the top of the socket, we don't want it to grow down. We'll talk about that it doesn't really grow down. It will never grow down until you have the first layer of periosteum start to form, because epithelium needs blood vessels directly underneath it to grow. It can't grow without it. So it's that way we remove the tissue as much as possible so the tissue doesn't collapse in and start to grow down somewhat. So that's the idea. You want to remove all the tissue as possible because that coal will grow back very, very easily. But if it stays there, it won't allow it to push all the way down and can have some soft tissue invagination. Okay, we've got Igor asks, new studies suggest keeping all soft tissue in the socket, saying that its structure will help attract osteoblasts and regenerate bone quicker with bone results. Your opinion? I don't see how that works on a cellular level. If you keep all the soft tissue in the socket, the body is trying to wall that off. So it'll keep putting down like scar tissue around it. It'll put more thicker, that tough, thick tissue around it, and bone won't have room to grow. So no, that doesn't, I think something's missing in the question, because that process would leave you, and I've seen it happen. You don't get rid of everything, you'll be left with thick, dense tissue and soft tissue, not bone. So no, that would not work. We've got Shauna Miller asks, how do you feel about Osteogen plug? I believe those are the plug. I'm not familiar with it exactly. I'm assuming it's one of the plugs with bone in it. So with those, I've used them and I've had them given me as samples. If you take a post-op x-ray of those, you'll see that it's like 80+% filler, collagen, and like a little bit of bone. So, and they're charging you not much less than just that same amount of bone. So it's not a dense fill. So I'd much rather either just put collagen if the socket allows it, which we'll talk about next time, or put bone and just forget these plugs. They're easy to use. So I would say that the putties and things like that, they're easy to use. And if you're not used to handling bone, it's a very easy thing to take out of the box and put in the socket. So I'd say for that, it's a good thing, but My biggest issue is that they don't have enough density of bone in them. So I'm not a big fan, but ease of use is yes. We'll talk about bone carriers and making your life really easy with some simple syringes very inexpensively. You'll see how I do that, and you won't need these expensive plugs. Do you use piezo? Yes, but not relevant to this question. So, I mean, I know some people will use piezos to extract teeth, where they'll use a piezo to push into the PDL space. It will vibrate and force water into the socket to remove the teeth. So ideally, it should work like Approximator does. But from what I felt, it was not really happening much faster. And for me, it's not just using the first thin instrument. I want to use progressively thicker instruments to stretch out the PDL because the piezo can't reach to the apex. So it's a good first start if you want to use a piezo as your like perio knife to cut around. It'll work. But to me, it's just an extra instrument to set up and to have there. Even though I have it on my bracket right behind me, I've got a piezo. I use my piezo almost exclusively for lateral sinus lifts, which if we end up doing a sinus lecture in this series, we'll see I'm rarely doing that anymore either, unless I have no option of crestal elevation. But so yes, piezos are nice instruments, but for me, it's not something I use often, but I know some people do and like it. And again, the concept is the same. You see what works in your hands. If you like to use it, should work really well. Okay, Christopher Rodriguez asks, so you added bone graft on that previous extraction. You did, but wasn't there infection still around the alveolus? How do you know when the graft is cleared away for the clear infection? Great question. So you never really know. You never know what bugs are still in there, and we're in the mouth. So even when you close in a pristine socket, even if you can somehow on a bacteria level verify that it's sterile, which it never will be, you still have oral bacteria soaking into your socket as soon as they close their mouth. The human body does a great job in the mouth of walling off bacteria. So I put them, if I ever put a graft or I put an implant, and this is a big topic of debate, I'm not yet ready to let go of it, but I give them antibiotics as a standard because I can't get rid of all the bacteria. There's always going to be some oral bugs there, and I don't want them growing on whatever I just put in there. So I give it as a standard. I give a week of amoxicillin or clindamycin/Z-Pak between those three as a standard to anything foreign I'm putting in their body. I will give them antibiotics. But again, I know that's a point of debate where dentists are being accused of over-prescribing antibiotics. I would just tell patients, let's say 80% of the time I would do this procedure and you'd be fine if I didn't give you antibiotics. But 20% of the time is a lot. Like we see, that's a few patients a day we'd have coming back with infections. So it's just not practical, I think, to not give antibiotics in reality. But again, as the research proves me wrong, I'm happy to be proven wrong and change my practice in the future. What is the benefit of using collagen plug over traditional ridge preservation with bone graft and membrane? So loaded question with a lot into it. My next section will discuss it at length, so I'll leave it for that. Brandon asks, if you are sectioning all teeth, are they all surgical? So yeah, that's a great question. I charge the exact same amount for a surgical extraction, except for wisdom teeth, as I do for a simple, quote unquote simple extraction, because I'm approaching them all the same way. And some teeth I look at and I'll say, that's going to be really difficult, and I'll get it out pretty quickly. And some I'll say that should come out really fast, and I'm in there for a while until it wants to let go. I never rush through a procedure just because time doesn't allow me to, and I'd schedule with enough time. I like to give my staff room to breathe in between. And if something took longer, we have some built-in buffer space to be able to move. The next room is set up. I can jump into the next patient. I'll catch up my notes later, but we'll still be moving. But I charge the same amount for every extraction. I know that if you're insurance based, that's not going to always work. So you're going to have to economically make it up on your bone graft. But you'll see time-wise what these extractions are taking you. And that's where, when we get into the world of insurance, it's much more challenging because you know, you have to do a lot with a little. And if you're going to be accepting insurances, know that you may break even on the extraction. And you just wasted, you know, an hour of your time, but you then have an easy implant. So that's where you'll be making your profit back. So what I'll do is we'll package the treatment plan. So the day the tooth comes out, we've already treatment planned the bone graft, which you're doing the same day, and the implant. And again, if you're a restorative doc, you're doing the abutment and the crown. So package it all together and look at each of those steps, how many visits, how much time each visit, break it down over a full procedure, and then say, okay, I may be breaking even if I'm looking at this extraction alone, but by the time I'm done with this restorative work, it's a highly profitable part of dentistry. So you're still going to be out way ahead. But if you didn't take the tooth out well and now it's got a major defect, and now you're referring out that for further grafting and the implant's going to be done by that other doctor, you've lost a lot more. So look at it long, the big picture, to make sure that you're still remaining profitable. But great question. Layla asks, how do you manage subcutaneous emphysema if it happens in a chair? So I will say first, I'm fortunate not that it's never happened, but what you should do is first, if it's an upper, it's not life-threatening. The only time it could be is if it gets into the airway. So if it's a lower tooth and it gets into the airway, if they're having airway distress, yeah, you're calling 911. That patient may need to be intubated because it could spread very, very quickly down to the area. So don't let it happen. It's a very preventable situation. You know, I know what happens with endos. It can happen by using air water to force air into the canal. Don't do that. Use surgical handpieces or electric handpieces when taking out teeth. And again, it's an instrument that's going to add a cost to what you're doing. But again, a surgical handpiece can be found relatively inexpensively. You don't have to get the fanciest one out of the gate. Get a good one that will work. And again, these last a long time. So per procedure, you'll be making that up very quickly. And when you're working the posterior, if you've never used them before, you'll be like, oh, wow, this is how you take out this is how you could treat a second molar and section it. Now it all makes sense. So it's a worthwhile investment. What are your go-to bone mixtures? Again, we'll talk about that the next section of the lecture. Is collagen sponge prone to infection? I'll say no. They're not, even though you would think it's wicking up all the bacteria in the mouth. Again, the mouth is very durable and rarely will get infected, but I will still put them on antibiotics as a cautionary. Eitan asks, can simple collagen plug delay bone forming? So the answer is, when done properly, no. But you have to be careful with bone collagen sponges. You know, the material I was using, you have to make sure that it's fully saturated with blood, that it's not just that you're putting it in, it looks red on the outside and you're done. Pump it in and out of the socket several times. Then if you're not sure, take it out, take a pair of scissors and cut into it. The same way as like you'll cut into a piece of meat or chicken to make sure it's fully cooked. You want to make sure that it's red all the way inside. Then you put it back in and make sure that, because if not, you're going to leave a dead space that's not going to really have blood cells to get in there. The socket will start to congeal, and there'll be a dead space in the center that's just not going to heal. So that way, that would delay formation, but short of that, wouldn't be an issue. Okay, what is partial extraction? I think we covered that. Dr. Khan asks, what are the complications during doing this procedure in patients with osteoporosis? Okay, so we talked briefly about the bisphosphonate drugs and how they work, that they are slowing the osteoclast formation and can lead to a necrotic socket. So I will say that. The reality is it's a very small percentage of patients who are oral bisphosphonates. IV bisphosphonates have a much higher significance. If it's heavy IV bisphosphonates, let's say in a cancer patient who's getting IV bisphosphonates, that's a contraindication to surgical treatment. Those you really don't do. I've had to manage several of those cases in residency, and those are not fun. So it's real. But what I've seen in practice with oral bisphosphonates is I'll see significant delayed healing, but they generally will still heal. Although the literature will say that it can happen. You can still get fistulas and it can get necrotic. So always be careful. What I'll do is, if people have been on bisphosphonates for a while, I will consult with their prescribing physician about doing a drug holiday. And there's you could Google Bronge, or now it's called with an M, Mirange, because instead of bisphosphonate related, it's medication related osteonecrosis of the jaw. That's the most recent term. Google the white paper on that, which is what the Academy of Oral Surgery has put out. I believe it's already a couple of years old, where they suggest doing a drug holiday for a few months. But again, they say it's not foolproof. So again, if you're a GP and you're new, just don't get involved in headaches. Just refer that case out. And let someone just who can manage these cases, manage more of these cases, take those on. But again, it's a good thing about being a GP, especially early on, is that you can punt the cases you don't want. Things that are complicated, out the door. You go to somebody else. I'll do the crown. But the straightforward cases, which is the vast majority of practice, then yeah, those are just you can avoid those. Okay, next we're down to our last 9 questions. I'm sorry, 19 questions. We have more. If the socket is clean, don't you prefer to put the implant in immediately? So I will say in some cases yes, in some cases no. If you're early, don't even think about it. You will no greater way to make sure you never do implants again than you screw something up badly because you've had to fight against a socket that wanted to put the implant through the buccal plate and out the apex, and you got to really force it in the right angulation. So if you've been doing this for a long time, then you can do it. Or if you're using a surgical guide, it makes it much easier, which we'll talk about down the line. Do it. But no better way to make sure you'll never do another implant is by trying to do immediates before you're ready. I tell people who take my course, it's not even on the table to discuss until you've done 25 implants. And I think that may even be too small a number. 50 may be a better number to do. But yeah, it's a case-by-case basis. Is it more convenient for the patient? Sure, in some cases it is. But the most inconvenient thing for a patient is a implant placed poorly, or worse, a mistake where, if it's a lower tooth and you're trying to force an implant into a molar, boy, you can end up through that nerve easily. So yeah, I would just say be very, very cautious. Crawl before you run, one step at a time. You'll get there. If you do implants, it becomes a big part of your practice to get there. But before then, yeah, not advised. Eitan Kamkaji. Hey, Eitan, how you doing? Haven't seen you in a while either. What do you think about the zero bone loss concept? Fantastic. Some of the most beautiful work I've seen done in modern implantology. Outside of the scope of here, but zero bone loss concept is fantastic. Google it. Some great lectures online of that. Doctor I believe out of Poland or Ukraine, forgot his name, but has some of those gorgeous lectures on modern implantology. So yes, great topic. Will you clean it with chlorhexidine or others? So I don't personally clean with chlorhexidine. I am cleaning it with mostly with the handpiece is doing most of the job. So that's water from the lines in my office. If it was infected, I also flush it with sterile saline. There is a paper that says chlorhexidine can inhibit bone regrowth, but again, a lot of these things are hypothetical in let's say a long bone situation, not so much in the socket. I know people who use chlorhexidine to clean it out. I don't think you're getting any real benefit from it, but it doesn't hurt either. So people will use it. There's a paper against it, but I think practically you're not seeing very much problem with it. So it can certainly happen. Vlad asks, do you use water when you cut the tooth? Yes, absolutely. Is it sterile or non-sterile? Non-sterile. It's just water from the line. And antibiotic afterwards. Yes, antibiotics afterwards, as we discussed. If you use non-water, again, the patient's numb, but it just will stink. And you'll burn bone also, because you're going to cut into the bone once you cut through, and the heat will just not be fun for anybody. So yeah, always use water. Michael Epstein asks, what is your opinion about alloplastic materials for grafting? We're going to get into it next. Great question. Mohammed asks, what can I do after extraction for precautions if I didn't place anything into the socket to avoid complications? So I would say put something. Again, this is just to avoid dry socket and keep your clot intact. So you can use any kind of collagen. You can use PRF if you're doing that in your office. You can use any kind of what is that older material that we used to use? It's like a little spongy thing. I forget what it's called. We used to use it in residency just to stop clotting. And you can use a small piece, cut a small piece off and just wet it, put it in the socket, put a small chromic suture over it just to keep it so it doesn't spit itself out. And you will avoid so many complications. Gerald Bolding asks, you mentioned using carbide football board to remove the PBL and other tissue in the socket and around the coronal aspect of the socket. Yes. Can you describe this process in more detail? I use electric handpiece. What are your settings besides turning off the air? Okay, so this is one of the greatest advances in terms of making this procedure go more efficiently and making sure you really clean things out well. So again, surgical handpiece. If I had the order number, I would love to display it of the burr that I use. You know what? If you're interested, shoot me an email. Again, implant, INPLANT, MSS, M is in Mary, SS, at gmail.com. I'll put the email address up again in a moment. And shoot me an email and I'll send you back the part number. Or in the next course, I'll even get it then the order number for that part. I get mine from Brasseler, but you can Google it and just see what it looks like and get something similar from whatever country you're in if they don't have it available. And you can reuse it a million times. I like it actually better, a little bit dull than when it's fresh out of the package because, again, I'm not looking to cut. I'm looking to just, kind of thresh from the sides and get it all out. Okay, next is we got Mohammed asks, when we know the bleeding is good for healing, or is it bad from granulation tissue? So when the granulation tissue is removed, then we're going to have good healing. And what you'll notice is you have a lot more bleeding when you have granulation tissue present because the body is bringing a lot of cells to try and wall off that infection. So the body has brought an abundance of blood vessels into the area to try and wall off the tissue. But if you remove all of that granulation tissue, most of those extra blood vessels have been, decimated. So you're just left with the upstream parts of those blood vessels, which would bleed in a healthy way, but not like profusely bleeding. When you have profuse bleeding, what oftentimes is the case is you've hit some kind of a small arteriole, and sometimes you'll see that it's pumping. You haven't, done enough extractions until you've done one, and you have a blood vessel shoot you in the face, or hit the ceiling, or hit your assistant in the face. That's when you've done enough cases. So in those, what you've done is just hit a small artery. Don't panic. Just put pressure on it. Take a small piece of collagen, or there's different clotting materials to use to place on it. Put firm pressure, and that will usually stop that bleeding. You can also use, in some cases, I'll use a heated instrument to just clot it with heat. So I'll take, in residency, what we did is we would take like any small surgical instrument, take a Bunsen burner, get it red hot, so it's sterile and hot, put it in, you'll hear a sizzle, and that's it, cuts it off completely. In my office, I use a disposable electrode, does the same thing, but they'll all work. So just do something to get the clotting. Pressure is usually enough. If not, use something else to get in there to clot it, to get direct pressure on it to stop it. Okay, Joseph Yasser asks, if after I put the implant immediately and bone grafts and suturing for 10 days, the healing after removing the sutures wasn't very well, and the gap decreased without complete healing. Why? Hard to say without seeing a case. If you have any x-rays or photographs of it, feel free to send them to me and we can discuss it. But I think what you're asking is, 10 days later, something wasn't healing well. So it could be a number of things. When we get into the implant part, we'll talk about complications and why that would happen, and it would probably answer your question then. But again, if you have a more immediate question, feel free to shoot me an email. Sandor asks, does intraligamental anesthesia affect healing? So not so that I'm aware of. Hypothetically, with the epinephrine, could cause the blood vessels to close up. But in my case, I'll do whatever I need to do to get them numb. So I'll use a PDL injection all the time. That usually works when the patient is going numb hard. Yeah. So when you need to get them really numb, use a PDL. It works great. I'll inject directly into the socket if we need to, and yeah, works really well. So I've not seen any effect on healing. When Paul Springs again asks, when remove the coal, we talked about the coal question a minute ago. Hezi Sasson asks, do you rinse the socket with iodine? So I don't. I have one doctor that I worked with who, before he would make any incision in the mouth, he would wipe everything down with iodine. And his argument was, you'd never have a surgeon make an incision anywhere in the body without first cleaning it with iodine. And I said, that's true if you're talking about epidermis, but when you're talking about mucosa, it's just not the case. Well, the iodine in the world is never going to get your mucosa in the mouth sterile. So you're always dealing with bacteria. We're just, again, fortunate to be doctors of the mouth where healing is very forgiving. So no need for iodine. Michael Kleeman asks, in the case of extraction of a tooth with a radiolucency, do you ever use chlorhexidine to clean the socket prior to grafting? So again, we talked about it's much more a matter of physical removal of tissue than it is sterilizing per se. So we want to remove anything that bacteria would grow on or has grown on, rather than getting rid of microscopic bacteria, which we never can. Ever use a piezo for atraumatic extraction? We talked about that. Jose Vargas asks, any preference for xeno, allograft, autografts? Excellent question. We'll discuss next time. Dr. Springs asks, leaving healthy PDL has been shown to improve healing response. I need to see a paper. I don't understand how that would work. The problem is there's no way to tell what's healthy PDL and granulation tissue. Again, I'd love to see a paper that says otherwise, but if you leave healthy, in my experience, if you take out a tooth that just had a fracture at the gum line, no infection, everything's totally healthy, take out the tooth, don't clean the socket well, you will have significantly delayed healing, because the areas where the PDL is will still have a blood supply to the PDL from the bone marrow, so it's still there and alive. So you have live tissue sitting there. It's a ligament, so it's not a blood supply per se. That's not receiving a blood supply, but again, it's also stopping the blood from the bone from perfusing into the graft and allowing it to heal well. So I'd love, if you have a paper on it, love to see it. Please email it over. But in my experience, you want that as clean a socket as possible. What is your go-to bone graft material? We'll talk about next time. In short, the answer to that question is they all work. Like, they really all work. You just have slightly different properties and healing and things like that where you'll prefer one over the other. But if you have any one, I find the gold standard being an allograft, which is human bone, a cortical cancellous mix. That's what I use for vast majority of cases. I find that the soft tissue heals well around it as well as the hard tissue. I don't have a great reason why, but that's what I've seen. But I've used every graft under the sun. They all work really well. So it's less important of what you're using, is that you're having a clean socket to put it into and some kind of a scaffolding to hold on to. Okay, what is the chip function of the electric handpiece? So what I believe it to be, and please correct me if I'm wrong, I haven't done restorative dentistry in a number of years, is it mimics the blowing of the air-driven part of the handpiece. So where an air-driven handpiece is constantly forcing air through to wash away the caries that you're trying to remove, this is to simulate that. So it's pushing air through to push away, because it doesn't need air to spin the handpiece. It's flushing water, but it's not nearly as much force to flush away what's there. I believe that's it. But if I'm wrong, someone please correct me. Christopher Rodriguez asks, zero bone loss concept is from Lithuania. Yes. Those are, yeah, it's really phenomenal lectures. Very impressive clinician. I'd love to meet him in person one day. Very impressed with his work. Do you place implants with polished necks? We'll get into that in the implant section, but the short answer is, unless it's a tissue level implant, which I'll use sometimes, no. We want implants placed at the bone level, if not significantly subosseous. But we'll get into all that later. Mohammed asks, what about chlorhexidine? We talked about that. Again, I'm assuming this is more of a European or Middle Eastern concept. They don't see it much in the States. But again, there's no, even though I've seen a paper that talks about a potential downside to it, I don't believe in practice there's really a downside. I think non-sterile water works well, sterile water works well, and chlorhexidine is just a sterilized version of that. I know some people will just flush it out with local anesthesia because it's sterile and it's liquid and will flush. That'll work all well too. So they all work. Gel foam, thank you. I was looking, Aviad told me that the term I was looking for of the very diffuse, soft material to help with clotting is gel foam, and that will work well to just hold your socket, the blood clot in your socket. Not that it's preserving the walls per se, it's just preserving the blood clot in your socket. Kruba Karen asks, please tell me about plaster jigs. I don't understand the question. I don't know what a plaster jig you're referring to. So I don't know if there's a misspelling or something there. So if you could rephrase that question and try again, I'd be happy to answer. Mohammed asks, I have seen some doctors use local antibiotic irrigation after extraction. Could that help? Sure, it could help. Again, you know, with any of these add-ons, and there's a lot of it, I think in dentistry we do that more than our medical colleagues, is that we do things very like, it couldn't hurt, and let's try it. And until the paper to prove that what you're doing is helpful or otherwise, you'll keep doing it, unless you have negative results, in which you stop doing it. So my mentor used to use, what was the name of it was an eye drop. It'll come to me in a second. But it was like an antibiotic eye drop he would wet his implants with. And he did that for years. And he's like, I do it in every implant. And I did it also because I went to the practice and that's what I did. And then I stopped and we had zero difference in rates of failure. So it was just wetting the implant. That was great. And we'll talk about wetting the implant later. It's really important to get it in to not have air bubbles left around your implant. But those are just things that we do because we do, but not because they're based in science. So an antibiotic, if it wouldn't work or had a higher level of efficacy, there would be papers published and we would all be doing it. The fact that we're not and we're just kind of doing here and there, by that proves that dentistry is working just fine without doing that. So again, couldn't hurt, but I don't think anyone has to go out of their way to add it to their armamentarium. PDL contribution from Dr. Springs. Okay, you left me a link. Thank you. Okay, I'm going to check this out afterwards. Let me see if I can. You know, Paul, if you don't mind, I can't cut and paste it. So if you don't mind emailing that to me, I'd love to take a look at it and we could discuss it at the next lecture. Okay, next question. We have two more left. Joseph Yasser asks again, I left the suture for 14 days and there isn't complete healing of the flap. Remove the suture or leave. Depends on the type of suture. So silk, yeah, it's going out because silk is wicking bacteria. If you're using a Teflon suture, you leave it in for as long as you need it to because it's pristine against the tissue. If you have something in between that's full of bacteria, I would much rather get rid of it. If your flap hasn't healed after 14 days, and what I mean by flap healing is that it's not now adhering to the bone, then you've got a bigger problem going on underneath. That should be happening. The suture's there, it's holding on, and it hasn't adhered to the bone. You've got something else going on. So again, send me pictures. If you have clinical photographs, that'd be great. If you have x-rays, that'd be fantastic. And we can see it further. Mohammed just says, thank you. You're welcome. And Saba asks, what is your recommended suture? I would say my most commonly used suture is the chromic gut. Chromic gut will last for 7 days, and in most cases, that's what you need. That being said, when you're doing larger things that you need sutures to last for longer, I'll use nylons, I'll use Teflons, I'll use some that are longer dissolving tissues that are very specialized sutures that are more expensive, but they are very helpful. But if you're going to get one suture in the office, chromic gut every day of the week. It's your best go. It'll last long enough, but not too long, and not have to come back for post-op removal of sutures. The easiest suture to place is silk, for sure. Easiest suture to place is silk, but it wicks bacteria really badly, so you have to bring them in 7 days, and you always see irritated tissue around the silk. But if you just want the ease of placement and don't mind bringing them in for 7 days, silk is a great alternative. A quick trick with chromic is people don't like chromic because chromic tends to feel like straw when you take it out of the package. What you do is take it out of the aluminum wrapping, and it's in a paper wrapping after that. Drop it in a cup of water for 2 minutes. You'll take it out, and it can then has the same feel of silk. It's like silky smooth at that point. So a quick little tip to use chromic and enjoy throwing it and tying it. Good. All right. I think that's everybody.
That was a very impressive webinar, and thank you for taking the time to answer everybody's questions. And we look forward to hearing from you next week with 2 more follow-up webinars. And
okay, looking forward.
Excuse me?
Good. And if anyone's interested in more in-depth stuff, we're going to go through this as like a basic continuum. I usually do this as a 1-day course. So it'll just take us a while to get a few steps. But if we want to put together smaller groups of, blue sky plan we've talked about doing, if there's interest in some sinus grafting, crestal sinus grafting, we could talk about it in smaller groups for longer periods of time. I'm happy to go through any of those. Any other suggestions, email myself, email Michael. Again, we're all home. We want to help everybody do as much as we can. So let's just use the time as best we can. And I'm myself taking a lot of CE right now online, but I'm more than happy to share whatever I can with everybody.
And we have the links on the screen, so follow the websites and the Facebook groups regarding upcoming webinars, additional webinars, and any scheduling issues. As I mentioned at the beginning, your CE should be emailed to you within a week or so. So you click out in your email inboxes, and please be patient with that.
Yes, and 3D printing. I forgot to mention. If anyone's into 3D printing and wants to discuss, smaller groups on how to print, get starting with printing, different printers, we can do a small group on that as well.
And Robert, there are lots of comments coming in on the webinar chat. I don't know if you've seen that yet, but most of them are thank you and appreciation comments.
You're always welcome. Oh yes, okay, I see it. Webinar Zoom chat. Okay. Yeah, if there's any questions I did not get to, I see a lot of thanks, and you're always welcome. It's my pleasure. So I see a couple of questions about live courses. So again, we do a few live courses I do in New York. I actually had one planned for an Israel course in May, which we canceled a couple of weeks back. We thought Israel was a nice central location to bring in people from Europe, people from the far or in Eastern Europe or in the Far East, and the United States is a far trip. We will hopefully get that as soon as world travel gets back to some semblance of normal. We'll come up with a date to do that.
Okay, do you want to share your website or any contact information?
Good. What's that?
Do you want to share your website or any contact information where people could reach out to you?
Yeah, so again, it's if I share my screen again, I'll put back my email address. Let's share this. I'll just get back to the beginning of the screen. It's got my information on it. Whoop. What happened there? No, that wasn't it. Hang on, I was after the lab Pronto. There we go. There we go, that's me. Okay, that's the best email address to reach me at. Again, any questions, CT scans to send, to review, just anything like, here's a case, I don't know what to do with it. I'll also send some links, maybe the next one. I have a Facebook group that we just discussed. It's called Case Collaborators, where we just collaborate with different specialists about complicated cases. When people will post and we'll all discuss. I do it live in New York once a month, and we'll just do it on the Facebook group all the time. Blue Sky Bio Facebook group is outstanding. Dental Town is a great resource as well, just of people doing what we all do, and happy to share information freely.
Okay, great. Thank you very much. And on Monday, we have Dr. Corey Glenn scheduled to talk about surgical guides. So everybody's
Yeah,
ready.
don't miss Dr. Glenn. I plan to be there as well. He is, if you haven't heard him before, he's one of the pioneers in the field, and this was his brainchild. So really, much thanks to him.
And Robert, much thanks to you, and thanks to everybody for attending.
All right. Have a great rest of your day, everybody.